So, I think can we switch off the lights? है ना? Yeah. So, welcome to Ulcer Stories and be ready to play this short game. So, in our ulcer journey, we have to be in D company. D does not mean Dawood Ibrahim. D stands for document proper history, medical records, and particularly the ulcer characters. Second D is make a diagnosis, and if not possible, make a list of differential diagnosis. Sometimes it's not very much clear on the first go. Then choose a drug, then choose a dose. In dose, it's very important that you realize that in ulcers, we need initially a dose during sterilization phase, and then we need to reduce the dose during the healing phase. So starting with the first story. This 41-year male, he had some wooden body fall in his eye. He removed on his own. And next day, he realized that there is some problem. Visited ophthalmologist. Ophthalmologist started moxifloxacin in too early dose. After 2 days, when he again visited that doctor realized that patient has worsened with moxi too early, and that patient was referred to me. So in this case, as you can see, most of the infiltrate is central. It's patchy. There are few satellite lesions, and there were endoexudates. Sorry, I don't have the slit lamp picture, but there were some lesions which were on the endothelium only. So most of our ulcers are bacterial or fungal, though there can be sometimes rare organisms. So major thing is initially to know that in what category it falls. So in institutes, they do the detailed workup. When you will go out in your practice, you might not have access to all these. Even if you just do the scraping for the smears, that will be enough in many of the cases. Most important thing is KOH. I have made a 10 minutes video. If you are interested, you can go to YouTube channel and see it. And initially always do a stain, know where is the defect, and that is the point from where if you do the scraping, the chances of getting a yield will be maximum. So we did scraping, both KOH and grams were negative. So as we usually do, if both are negative, we treat it as a bacterial. So we thought that, okay, we will treat it as a bacterial ulcer. Now comes which drug you use. As you know, if the ulcer is small and superficial, we go with the monotherapy. We choose a 4th generation fluoroquinolone. And if the ulcer is severe, then we go with the combination therapy, where we choose one drug for gram positive and we choose one drug for gram negative. Okay, and you must remember that whenever you have made a fortified drug, it should be re-prepared after 7 days, and it should always be kept in. Can I have some interaction? Where should be the fortified drugs go? Not in phone. Where should a fortified drug should be there? Have you ever made a fortified drug? Then what do you tell your patient? Put it in fridge. Okay. So initially the dose should be 1 hourly. That period can be 2 to 5 days depending upon the response you see, because at that time we want to kill most of the bacteria. No NSAIDs. And even lubricants don't have any role unless patient is having concomitant problems like dry eye. Otherwise, the ulcer patient is already watering a lot. And then you have to taper the drugs. So I started these drugs, and then I examined patient after 2 days. Now is your turn. This is the game. This is after 2 days. You have 10 seconds. Is there any difference between these two? Chalo, 10 seconds are over. No response. So this was the area of endoexudates. So endoexudates have decreased. But the most important thing is somewhere else. If you notice this area from 3 o'clock to 6 o'clock, this area was very hazy here. And now this area is clear. This is one of the most important indications that our drugs are working. So pre and post, this area was the area of cellular reaction. Near the infiltrate, you will always find lot of WBCs, which give the haze to the cornea. If the cornea is responding, that haze will decrease. So always look for that area. Other positive things are if the patient is subjectively feeling better, hypopyon is less, the density is less. And if your patient is not improving at all, always check compliance. And third thing, if your patient has worsened, always repeat KOH. You might have missed it in the first go. And then you start decreasing the drug. It is very essential to decrease the drug. So I decreased the drugs. This is how the patient looked at 1 week. At 2 weeks, when most of it has healed, then we don't need to continue fortified. We can change to monotherapy also. And this is how the patient looked at 2 months. So the importance of cellular infiltration is that, suppose this is the patient who got injury post-accident. He got redness in the eye. Infiltrate was very small. Sometimes if the infiltrate is very small, it is too much in the periphery. Sometimes we don't scrape. So in this patient, I did not scrape. I started the patient on antibiotic only. When patient came after 2 days, do you feel the infiltrate has increased or decreased? Deaf and dumb. At least you can tell it has increased, decreased. Infiltrate appears, increase. It has increased a bit. But then I told you there is another factor. Always pay attention to surroundings. His surrounding area was clearer. So sometimes it happens that during the consolidation phase, the infiltrate slightly increases the size. But if the surrounding area is better, you can observe the patient. There is no need to further increase or add the drugs, making it a cocktail. Otherwise, it will worsen, as it happened in our last case. This patient was using contact lenses for last 25 years. He occasionally used to sleep with those. So he got some ulcer. He was referred to me with this. Ulcer is looking very dense. 6 days back, he consulted our doctor. At that time, he was put on this cocktail, Neta, Amica, Moxie. No scrapings were done. Even oral antibiotics were given. And after 2 days, furthermore, Vanco, Cefta were also added. And when he did not respond, he was referred to me. So this is the picture at his present. So as you can see, the surrounding area looks pretty much clearer. Hardly any cellular infiltrate, no edema. And when I did the scraping, I realized that entire dense looking thing was just a necrotic mass. It just came out like a pus. And on scraping, there was no organism. So I stopped all the drugs, put only on Moxie 6 times a day. And this is how the patient responded. So ulcer is not only about increasing the drugs always. So always document, note the surroundings also, always do KOH, and if patient is not responding in your hands, always refer. Thank you so much.
Thank you, Dr. Sujata, for excellent presentation and excellent stories. I would just mention one thing that I have also one patient who was like French national, and he was visiting Dharamshala using contact lenses and came with very severe pseudomonas keratitis, total corneal involvement. So I asked him that what you did and how do you take care of your contact lenses. I was sure that he's from a country which we think is very cleanest and all. So what he told me that I was cleaning my lenses with saliva. He thought his saliva is more cleaner than our water or our contact lens solution. So in contact lens patients, the contact lens care is the most important. I would now request Dr. Ashish Ahuja to present his topic on dry eye. Please, Dr. Ashish.